And so now I invite Dr. Jeff Kline, AEM Editor-in-Chief, to the stage here and join me in introducing the 2022 plenary abstracts.
Thank you, Dr. Beam. It's my pleasure and honor to kick off the plenary session for SAEM22. I have to follow the script, but let me go off for 1 second and say there are more than 20 beautiful empty chairs right here and probably the same number over here. Just saying. I get the pleasure of being part of introducing 4 of 8 plenary session topics that were picked using an objective and rigorous process from over 1,500 abstracts. We'll hear 4 today and 4 tomorrow, and the 4 tomorrow will be presented by Dr. Susan Promise, Editor-in-Chief of Academic Emergency Medicine, Education and Training, AEM ENT. So with that, I'd like to invite our first presenter. We've already met him. Dr. James Holmes will present validation of the Pediatric Emergency Care Applied Research Network Abdominal Trauma Prediction Rule. Dr. Holmes.
Thank you very much. It's an honor to be here. I'd like to thank SAEM and my collaborators, and we will present validation of the PCARN Intra-Abdominal Injury Prediction Rule. I have no financial or other conflicts of interest, and this research was supported by a grant from the NIH. Abdominal trauma is a common, serious problem. Abdominal CT use has increased substantially in the late 1990s and early 2000s, but only 10 to 20% of children that currently undergo abdominal CT scans actually have intra-abdominal injuries, and a much smaller percentage of those have intra-abdominal injuries that ever need any specific therapy. There are disadvantages of CT, including radiation, costs, incidental findings on the CT scan, transportation and time, and the potential need for sedation in the very young children. And as we've learned recently in the last week or so, the need for IV contrast, which is now on a shortage nationwide. There is little consensus regarding the indications for emergent abdominal CT in children, and in 2013, PCARN published the Intra-Abdominal Injury Prediction Rule, which looked at variables to predict intra-abdominal injury in need of acute intervention in injured children. That study of over 12,000 patients identified a prediction rule. Unfortunately, that prediction rule has not been prospectively externally validated, and essentially based upon criteria, it is a level 4 prediction rule currently that should not be implemented. These are the variables in the PCARN Intra-Abdominal Injury in Need of Acute Intervention Prediction Rule. That includes Glasgow-Coma scale score less than 14, evidence of abdominal wall trauma or seatbelt sign, complaints of abdominal pain, abdominal tenderness, evidence of thoracic wall trauma, decreased breath sounds, and vomiting. Children without any of these risk variables are very low risk for intra-abdominal injury undergoing acute intervention, such that CT is generally not recommended. The objective of this study was to validate the PCARN prediction rule for identifying children at very low risk for intra-abdominal injury in need of acute intervention, such that CT scans could be avoided. We hypothesized that the PCARN abdominal injury prediction rule can be validated in a new large multi-center cohort. An application of this prediction rule will reduce the overall number of CT scans in the study population without missing an intra-abdominal injury in need of acute intervention. This was a prospective multi-center study from December 2016 through September 21, including the time of COVID, which pediatric trauma numbers dropped significantly at institutions across the country. We included children less than 18 years of age without blunt abdominal trauma, and the exclusion criteria are listed here below, but I will point out that any child that presented more than 24 hours after their time of injury were excluded, as well as those that had a strong suspicion of non-accidental trauma. The PCARN data were recorded before abdominal CT, if an abdominal CT was obtained, and physicians documented if the prediction rule was positive or negative, and if the prediction rule was positive, the clinician was asked to document which of the variables were positive or negative. And here we see the actual data collection form for that particular question, where the clinician is queried, is the patient positive for any abdominal prediction rule, yes or no? And if it's yes, they are asked to document which variables are positive. We also assess inter-rater reliability of the prediction rule, and so we had 2 physicians independently evaluate a patient subset to see what the inter-rater reliability of the rule is, and that was measured with the kappa statistic. Abdominal CTs were obtained at the discretion of the treating faculty physician and interpreted by site radiologist. We obtained follow-up on all patients. Those that were discharged from the emergency department underwent telephone or text follow-up at least 1 week after the initial ED visit to determine if they had had any additional clinical findings or abdominal imaging after they were discharged from the emergency department. Hospitalized patients were followed and had their medical records reviewed for interventions and outcomes. The outcomes included intra-abdominal injury, which included any solid organ or hollow viscous injury identified by CT, MRI, laparotomy, angiography, or at autopsy. The primary outcome of interest was intra-abdominal injury undergoing acute intervention, which consisted of death from that intra-abdominal injury, therapeutic laparotomy, therapeutic angiographic intervention, blood transfusion due to intra-abdominal injury, or in those patients with GI or pancreatic injuries, they were kept in PO for 2 or more nights. Our sample size was based upon 2 different measures. For a lower bound of the 95% confidence interval of a negative predictive value greater than 99.5% and a power of 0.8, we would require 2,360 patients who are negative for the prediction rule. For a sensitivity of greater than 98% with a lower bound of the 95% confidence interval greater than 95% with a power of 0.9, we require 55 patients with the outcome of interest, which was intra-abdominal injury undergoing acute intervention. We ultimately enrolled 7,542 patients. 57% were male. The median age was 9.6 years. 33% underwent abdominal CT. 7% were identified with intra-abdominal injury, and 147, or 2%, had the primary outcome of interest, intra-abdominal injury undergoing acute intervention. Of the 147 with the primary outcome, these were the variables that made that up. And as you can see, blood transfusion, laparotomy were most common, with angiographic embolization and death from the intra-abdominal injury being rare. Obviously, they add up to more than 147, as many of the patients had multiple of these interventions. The inter-rater reliability of the rule, we measured that in 448 patients, or 6% of the population. The kappa measurement was 0.69, which indicates substantial agreement of the rule. That is, independent raters could determine with substantial agreement that the rule was positive or negative. These are the test characteristics of the prediction rule. Of the 147 patients that had the outcome of interest, all 147 were identified as abnormal by the rule, giving a sensitivity of 100%. The specificity was 47%, and the negative predictive value obviously was 100% as well. These test characteristics are slightly higher than the test characteristics in the derivation sample. 46% of our population were considered low risk for intra-abdominal injury undergoing acute intervention by the prediction rule. 461, or 13% of those patients, underwent abdominal CT scans. That means that 19% of the CT scans done in the entire cohort were done in patients that were very low risk that are unlikely to benefit from that CT. There are certain limitations to the study. Not all patients eligible were ultimately captured, but our enrollment rate was over 80%. Also, not all patients underwent abdominal CT scanning. However, everyone had clinical follow-up to assess the presence or absence of the primary outcome of interest, which was a clinical outcome. So in conclusion, we validated the PCARN clinical prediction rule for children at low risk for intra-abdominal injury undergoing acute intervention. Patients lacking these variables are at very low risk for intra-abdominal injury undergoing acute intervention. CT scanning is typically not warranted in this population. And this prediction rule is ready for widespread implementation. In fact, this study will bring it up to a level 1 clinical decision rule. I'd like to thank our research manager, the research coordinator, and site PIs of the validation study team, as well as all the physicians and nurses working in the hospitals that participated in this study. Thank you very much, and I will entertain any questions.
This abstract's open for questions. Please come to the mic. We really only have time for 2 questions. If you could just identify yourself and your institution, and please ask a question.
Hi, it's Ian Steele, University of Ottawa. I want to congratulate you on a beautifully done study. Met all the standards for prospective validation. One question I have, what do you predict, or did you calculate the potential impact on scanning? Because it seemed to me a lot of kids already didn't have a scan. And will your rule in the study sites anyway increase or decrease the use of scanning?
Yeah, a very good question. I think even though the rule technically is a level 4 rule, I think we've already seen impact for the study. This slide right here shows the CT rates in the derivation sample as compared to the CT rates in the validation sample, and we see a 12% decrease in the CT rate in the low-risk population. So I think providers are already using this rule, and it shows some decrease, at least from what we were doing approximately 10 years ago. So even though maybe it shouldn't have been implemented already, I think people were already implementing it. As to the question about would it potentially increase CT rates, I at least think this data doesn't show. And the rule is not set up that if a variable is positive that they should get a CT scan. The rule is set up just to rule out the condition. And we're working on that intermediate risk group about recommendations for that as we speak. Thank you very much.
Hi, Dan Mayer, Albany, New York. In your process of medical record review, did you use the techniques expounded by Kaji, Worcester, and Gilbert and Lowenstein?
Yeah, we followed accepted rules for retrospectively reviewing charts, yes. All right, thank you very much.
Thanks, Dr. Holmes. So our next presenter will be performance of the European Society of Cardiology 0 1-hour algorithm in patients with known coronary artery disease by Dr. James O'Neill at Wake Forest Baptist Health.
All right, thank you for that introduction. It's great to be here with all of you. The Stop Chest Pain trial was funded by Roche Diagnostics, and we have a disclosure slide in the slide set. Chest pain is something that we see every day, and it's easy to get numb to the fact that this is a high-risk interaction for both the patient and for us. I was reminded of this the other day when one of my colleagues needed me to cover for him in the ED. He came in normally stoic with tears in his eyes, and he was concerned about his wife who was having chest pain. It reminded me that this chief complaint that we're very used to has potential for bad outcomes for people that we care about and love. As a physician, too, we want the best for our patients, but we also have that hanging over our head that the potential for missing ACS could have medical, legal, and professional consequences. Chest pain, we see 7 to 9 million patients a year in the ED. Greater than 50% of these patients are admitted. We know that our EDs are full of patients, full of boarders, and they take a lot of resources. Even when those patients are discharged home, less than 10% of them have acute coronary syndrome diagnosis. There's also a diagnostic dilemma about how do we take care of patients who have coronary artery disease in the past. ADPs, or accelerated diagnostic protocols, have been developed to try to take better care of these patients. And in the last few years, we've been able to incorporate high-sensitivity troponin. High-sensitivity troponins have been in Europe since about 2010. Recently, FDA approved in 2017 and 2018. One of the more common troponin-only ADPs that is used is the European Society of Cardiology high-sensitivity T troponin algorithm. It's the 0-1 algorithm. This is tested and validated in Europe, but also is used in the United States. It takes a 0 and a 1 hour troponin level and a delta, and it risk stratifies patients into either a rule-out zone, an observation zone, or rule-in zone. This study focuses on the rule-out zone and how well patients with coronary artery disease do. So the objective of this study was to test the ESC 0-1 hour high-sensitivity troponin algorithm among patients with and without coronary artery disease in a multi-site U.S. cohort. Stop chest pain trial was performed in 8 emergency departments across the United States and was performed between 2017 and 2018. Target population was a patient who is 21 and up who had any concern for acute coronary syndrome. I listed the exclusion criteria, but if they had a STEMI on EKG or were unstable, they were not included in that study. For data collection, patients were determined to have known coronary artery disease based on the treating provider. They had a previous MI, they had coronary revascularization, or a known 70% stenosis. We collected 0 and 1 hour samples, and we measured high sensitivity troponin T. And then these patients were risk stratified into one of those 3 observation, rule out, or rule in groups. The outcome of this study was MACE at 30 days, which included cardiac death, myocardial infarction, or coronary revascularization. All of these cases were adjudicated by expert reviewers. For statistical analysis, we looked at efficacy, negative likelihood ratios, negative predictive values for 30-day MACE. And these were for patients with known CAD and without known CAD. We obtained 95% confidence intervals. Efficacy and negative predictive value were compared using Fisher's exact test. Negative likelihood ratio, we're using Lutz's method for each pairwise comparison. We also performed a multiple logistic regression to look at the interaction between CAD and ESC 101 risk while adjusting for these following well-known confounders. So the results of the study were very interesting. We had 1,430 patients. 45% were female, 57% were white, and quite diverse population compared to other studies. The mean age was 57, and the overall 30-day MACE rate was 14.2. Looking at the total population, about a third of them had coronary artery disease. And this is the take-home slide of all the results, that when we looked at the patients who were placed in the rule-out zone, that the patients with known coronary artery disease, let me go back and talk about just how many patients were in the rule-out zone first. So looking at the rule-out zone, 40% of the patients with known coronary artery disease were placed in that zone, and 66.1% were placed in the rule-out zone from the no known coronary artery disease group. And this is my take-home slide. I was so excited I jumped ahead of. So for the patients who were placed in the rule-out zone, patients with known coronary artery disease had 7.9% rate of MACE at 30 days. And when you look at the no known coronary artery disease, folks who were placed in the rule-out zone had a 1.4%. And this is not hitting the less than 1% that we desire for an ACS study. Negative predictive value for 30-day MACE was 92.1% for the known CAD group and 98.6% for the no known CAD. Negative likelihood ratio was 0.28 for the known CAD and 0.13 for the no known CAD group, and that is not below the 0.1 threshold that we desire as well. For the multiple logistic regression, known coronary artery disease was associated with increased 30-day MACE among patients in the rule-out zone. This was not significant for the patients in the observation and the rule-in zone. So conclusions. In patients with known CAD, the ESC 0-1 hour algorithm had a high rate of missed MACE. These data suggest that using this algorithm should be used with caution with patients with coronary artery disease. I'd like to thank all the Stop Chest Pain researchers. I'd like to thank the Wake Forest team, especially two people. Jason Stepira taught me how to do a lumbar puncture 20 years ago, and it's actually a method that obtained fluid. And Simon Mahler has just been the captain of our ship, and I appreciate him inspiring us to take care of patients more than the ones that are in front of us. And open for any questions.
Adam Singer, Stony Brook. Congratulations, a great study. We really need this. However, you know, the guidelines that were published recently by the ACC and SAEM suggest that even in patients with known coronary artery disease, a high sensitivity troponin can rule out the need for further follow-up. So this is in contradiction. And I wonder, of the MACE, how many were PCI and interventions? Because if I know you have CAD, I'm more likely to then do a cardiac cath and do interventions, which may not have been necessary. So some people have talked about excluding from MACE coronary interventions because we never know if those actually truly were necessary. So I'm wondering, of those MACE, how many were significant things that happened like death and MI and not interventions that may have been performed unnecessarily because we knew they had CAD? And thank you.
Yeah, thank you. That's an excellent question. We definitely looked at the data. I have another slide just looking at death and MI by itself. It's hard to see even for me up here, but when we talked about the 7.9% rate, when you look at just cardiac death and MI, it's 3.9%. So it is less, but it's still significant and still higher than we'd like to see.
Thanks. This is an excellent study. This is Alec Lincoln from Duke. We know that these early rule-out protocols can be impacted by the time from symptom onset, particularly patients who present early, and there's a good reason to believe that patients with known CAD may present earlier to the emergency department. Do you think that might be an explanation for your findings, or do you know sort of the average time from symptom onset of your cohort?
I agree, that's an excellent question, and something that we need to look at further in our research, how these early presenters would affect. So we definitely had an early presentation group of 0-1 hour, but definitely studies looking at even quicker turnaround, 0 and 30 minutes, and there's more research to be done. So thank you for that point.
Thank you, Dr. O'Neill. Next up, Dr. Wesley Holland from Yale School of Medicine will present observed disparities in emergency department-initiated buprenorphine across 5 healthcare systems from the MBED pragmatic trial. Dr. Holland. Is it doctor?
No, I'm a medical student, but thank you.
Mr. Holland.
Mr. Holland, yes. Soon to be. So my name is Wesley, and this is our study. As you can see, racial and ethnic disparities in ED-initiated buprenorphine for opioid use disorder. So we have nothing to disclose other than the funding sources listed here. And I'm going to try to go through this pretty quickly because I think everyone understands this. So opioid crisis is bad. It's not getting better. COVID certainly didn't help. We have 93,000 overdose deaths in 2020, and 70,000 of them, which is the vast majority, were due to opioids alone. We have a solution, but medications for opioid use disorder are underutilized, with only like 1 in 5 patients actually receiving the medication for opioid use disorder, like methadone or buprenorphine. And that's kind of a shame because the ED is like a critical point of access for care for patients with OUD and other marginalized populations. And the annual mortality rate after an overdose is, it's pretty high, 5% in just 1 year following an overdose. That's a problem that can be addressed. But thanks to previous research done by our collaborators, we know that if BUP is initiated in the ED, they're twice as likely to be engaged in follow-up at 1 month. So With that in mind, we have the treatment, but historically, just increasing the access to MOUD alone isn't going to fix the racial disparity problem, because as you can see here, the graph, it shows buprenorphine receipt rate or percent on the y-axis and over time on the x. And you can see that a long time ago it was kind of similar. It wasn't too different. But as time progressed, whites were much more likely to have visits, like outpatient visits for OUD, and black patients were not likely to have, as likely to have the visits. And on top of that, really, even if they had the visit, at the visits, they were significantly less likely to receive BUP. So less visits, less chance of receiving BUP at the visits they had. So we know about outpatient, but what about inpatient? Or what about in the ED? What can we do about this? So, our question for this study is, are there racial and ethnic disparities in ED-initiated buprenorphine for opioid use disorder? And with that question in mind, here are our aims. So we want to characterize racial and ethnic differences in the receipt of BUP in the ED, and we want to also explore racial and ethnic differences in ED BUP administration by hospital level variables. So this is the data we use for our slide. It's from the MBED trial, which it's a large pragmatic trial of IT intervention for initiating BUP in the ED. And it was conducted across 22 EDs in 5 healthcare systems, each in a different state, between August 2019 and May 2021. And those sites were Connecticut, Massachusetts, North Carolina, Alabama, and Colorado. So the participants for the MBED trial, which again is the data set that we use for our study. So there was 5,047 participants. They were adults aged 18 years or older who had an index for initial visit to the ED for opioid use disorder between November 2019 and May 2021, as I mentioned before. And the diagnosis of OUD was determined by ICD-10 codes and chief complaint, and really just anything related to opioid use disorder. Patients were excluded if they were pregnant or they were already on treatment for buprenorphine, because we were more interested in exploring the disparities in initiating buprenorphine for the first time. So, our outcomes. So the primary outcome was basically just the proportion of patients who were administered or prescribed BUP on the index visit to the ED by race and ethnicity. And whether that was, administered in the ED, whether it was prescribed at discharge, one or the other, or both. Basically just if they received it at all, that was what we were looking at for the main analysis. And for secondary analysis, we looked at the BUP receipt by race and ethnicity between the type of EDs, like say community versus academic. And I'll get into that later. And for analysis, we used generalized linear mixed models with repeated effects clustered for site and provider to account for the differences within a site or within prescribing practices of a certain institution. So getting on to our actual variables here. So this is how we analyze race and ethnicity in our analysis. So we can see the race listed here. I'm not going to read them all out. And ethnicity was Hispanic or non-Hispanic, but based on prior literature, we combined them into 4 groups. So we have Hispanic, we have black non-Hispanic, white non-Hispanic, and then other. So basically, if they had an ethnicity listed as Hispanic, they were grouped into Hispanic, regardless of race, just to be clear. And then we also had this other group. So, all the other smaller categories like Asian, like Indian, Alaska Native, Hawaiian, they were very small, so we grouped them into one group. And also if someone was missing race and or ethnicity data, if they were missing one of the 2 variables, they were also grouped into this other group. So that's kind of confusing, so we're just going to focus on the main 3, Hispanic, black non-Hispanic, and white non-Hispanic for this talk. So let's get to the results. So patient characteristics, a few things are apparent. So if we look at insurance, we can see that Black, non-Hispanic, and Hispanic patients were more likely to have Medicaid insurance compared to white patients. And for diagnosis, we can see that Hispanic patients were more likely to present to the ED with an overdose, or like a diagnosis of overdose, compared to both white non-Hispanic and Black non-Hispanic patients, who both had lower but kind of similar rates of the overdose diagnosis. And Black patients were also less likely to present in withdrawal. So that's patient characteristics. Let's talk about ED characteristics. So if we look at the type of ED, whether it's academic or community, Hispanic patients visited community and academic EDs at about the same rate, more or less. But non-Hispanic Black patients and white non-Hispanic patients were more likely to go to a community ED. And Hispanic and Black non-Hispanic patients. Everyone visited urban EDs more, but the white patients were not so likely to visit the urban EDs compared to Black or Hispanic. They were more likely to go to either suburban or rural. But, okay, here's the main thing. So, receipt of buprenorphine by race and ethnicity. This is our primary outcome, specifically the first column. So if we look here on the y-axis, it's like the rate or percent of receiving buprenorphine. And then on the x-axis, we can see like how they received it. So did they receive it in any way? Was it administered in the ED, prescribed at discharge, or both? But again, the first one is what we're really interested in. Did they get it at all? But really across the board, you can see that Black non-Hispanic patients were the least likely to receive it by any means. Then here are the numbers kind of showing the same thing. So receipt of by race and ethnicity. So white non-Hispanic versus Black non-Hispanic, you can see that the white people were 1.43 times as likely to receive buprenorphine compared to Black non-Hispanic. And that was a significant value at p.02. And this similar comparison, Hispanic versus Black non-Hispanic, was also significant. And they were 1.89 times more likely to receive buprenorphine. But when you look at the Hispanic versus white non-Hispanic population, there wasn't a significant difference there. So this is our secondary outcome. So we're looking at community versus academic EDs in terms of racial and ethnic disparities in the rate of bupe prescribing. Because in the primary analysis of the embed trial, academic sites were overall just more likely to prescribe or had higher rates of prescribing buprenorphine compared to community hospitals. And we were wondering if that disparity kind of translated or related to a racial disparity. So there was like a disparity within a disparity almost. But we didn't find one. So we assumed that academic hospitals would have a smaller difference in terms of like buprenorphine prescribing by different races, because they have, robust opioid use disorder programs and they're up to date on the literature. But surprisingly, we didn't find that. Or at least not significantly. The bupe initiation by race between community and academic was pretty similar. So that kind of means this is a problem across the board. Yeah. So before here, we were analyzing race and ethnicity combined into those four groups, but we were wondering, because of all the missing data, and like whether they were missing race or ethnicity and they just ended up in the other group, like we decided to just look at race independently and ethnicity independently to see if the trend still holds in kind of a sensitivity analysis. And when we did that, this is the adjusted result, white versus Black. We can see like the trend's the same. It's still significant. White people, regardless of ethnicity, compared to Black patients with OUD, regardless of ethnicity, were significantly more likely to receive buprenorphine in the ED. But when we look at the ethnicity independently, regardless of race, we can see the Hispanic and non-Hispanic patients were similar. think I pressed the wrong slide. I'm pressing red. Oh, limitations. Okay, generalizability, that goes for any study. I mean, it was a large trial. We had 22 EDs, 5 different states, 5 different healthcare systems, but that, that's not necessarily a representative sample of the entire U.S. population. A few sites had significantly more Hispanic patients, and that could have interfered with our ability to draw conclusions from this analysis. But the main issue we ran into was the variable and inconsistent reporting of race and ethnicity data. Because sometimes that's like self-reported, maybe it's the registration person's best guess, maybe they just choose not to, if they're non-Hispanic, maybe they just choose not to say they're non-Hispanic. And for our analysis, if they were missing either race or ethnicity, they were in the other group. But we kind of addressed that with the sensitivity analysis, like the race and ethnicity independently. And the trends still hold either way. So conclusions overall, Black patients were significantly less likely to receive BUP in the ED compared to all other racial and ethnic groups. And surprisingly, racial disparities in ED-initiated BUP did not differ significantly between academic and community sites. So, this is an academic conference, so that's kind of a surprising finding, I feel like. Anyway, thank you. My name is Wesley Holland. There's my email. I'll be applying to residency in a few months. So, I'd like to shout out my PI and mentor in the mastermind behind the embed trial, Dr. Ted Meldick, and also the senior author, Dr. Bill Soares, for their patience and bearing with me and just being awesome mentors. I couldn't do it without them. Thank you.
Thank you, Mr. Holland. And despite the importance of the topic and the impact, because of time, we're not going to be able to take questions, but to move on to our final abstract.
Our final presenter is going to be Dr. David Kim, MD, PhD from Standford University, predicting myocardial injury from continuous single-lead electrocardiography in the emergency department.
Oh, perfect. Okay, I'm David Kim. I'm an assistant professor at Stanford, and I'm going to be speaking about some of the work that my group is doing with bedside physiologic monitor data in the ED. Thank you for staying after hours to hear my talk, and thank you for the opportunity to speak about early exploratory science in this venue. I don't have any disclosures. We in the ED routinely affix our patients to sophisticated bedside monitors that record high-resolution multimodal physiologic data across the course of the ED visit. The median monitored ED visit produces around 200 megabytes of waveform and numeric data, but the median amount of data that we actually enter into the EHR and therefore have readily accessible for our decision-making without staring at the monitor itself is this. It's less than a kilobyte. Around a year and a half ago, when I started at Stanford, our hospital had just started to store rather than discard the complete monitor data for ED patients, and my collaborators and I wanted to know whether we could make this new data source clinically and scientifically useful for the ED. What does that mean? One way to think about whether a new source of data is useful is by determining its impact on a prediction that you care about. For instance, can we model ED monitor data so as to predict the onset of hypotension in this initially normotensive patient? This is an example of what we call an in-signal prediction, meaning that the target outcome of prediction is included in the data that we use to make the prediction. And in some ongoing work, my group is modeling this data to predict unexpected hemodynamic decompensation in the ED and patient responses to therapies. But the work that I'm going to speak about today is a different kind, what we call an out-of-signal prediction, meaning that the target outcome is not contained or is only latently represented in the data that we're using for prediction. And in particular, we wanted to know whether we can use the continuous single-lead electrocardiogram data that we collect on ED patients to make a prediction about a diagnosis that's important to our specialty, but that lacks classic pathognomonic electrocardiographic stigmata, namely myocardial injury without ST segment elevation. So we did this by looking at around 11,000 monitored ED visits over the course of a year who received at least one troponin test in the ED. We excluded patients with chronically elevated troponin or with a diagnosis of STEMI, which would be a trivial prediction target for our task. And in model development and training, we permitted any chief complaint, whereas in validation and testing of the model, we allowed only patients presenting with chest pain and shortness of breath, such that a newly elevated troponin would constitute something like an NSTEMI by standard definitions. And this idea of being able to expose the model to more and more varied data in development and training than in validation and testing turned out to be important to the story, as I'll explain in a moment. We aligned the waveform data to visit events, namely patient arrival, rooming, collection and result times of troponin assays, patient departure, and we extracted the continuous lead-to electrocardiogram data from before the first troponin result. ED monitor data are inherently noisy and messy, and we had to develop a fairly complex quality checking mechanism to sample usable segments of patient monitor data and do so in a way that we could actually deploy prospectively. We repeated this process 10 times so as to multiply sample from different points in time, lead to continuous ECG segments for these patients, most of whom were undergoing ACS evaluation. We then trained a series of recurrent and convolutional neural networks on this waveform data to predict myocardial injury, and the initial prediction results were not worth showing here, meaning that we were not able to successfully identify myocardial injury on the basis of these waveforms. And we asked ourselves at this point, is that because there's no relevant information in this signal, or because we didn't have enough or the right kind of data to learn that relationship? And for anyone who's followed the recent advances in AI and deep learning, you'll know that the really prominent successes of deep learning have used millions or billions of observations, and at this point we had thousands. And this is the crux of the story. We developed a type of deep learning model that we call a waveform transformer. This is an adaptation of the sorts of trillion parameter language models that underlie the really dramatic advances in natural language technologies over the past 5 years. And we adopted what we call a pre-training approach, meaning that before we exposed the model to our limited study data, we trained it on a different data set of around 34,000 publicly available labeled 12-lead ECGs from the PhysioNet database. And importantly, myocardial injury was not one of the labels of these training ECGs. Instead, these were first-order ECG features like rhythm categories, axis, interval prolongation, and so forth. And the idea here was to see if we could prime our model to recognize basic features of ECGs, to parse the waveforms in the hope that that would lead to more efficient learning of the more complex latent representation that we were hoping to find. We did this pre-training, and then we fine-tuned our model on our actual study data, namely the multiply sampled lead-to continuous ECG segments and other patient features for our study population to produce a final prediction of myocardial injury, again meaning newly elevated troponin in patients with chest pain or shortness of breath. And now we were getting somewhere. We found that after adopting this pre-training approach, we were able to accurately identify myocardial injury just by multiply sampling the continuous ECG signal from the first hour of the patient's visit. I won't go into detail on the hierarchy of models we evaluated here, except to say that our primary model, which sampled 10 ECG segments from each of these chest pain or shortness of breath visits using the pre-trained transformer architecture, produced an area under the ROC curve of 0.76 in our test set in identifying myocardial injury. Using our pre-specified operating point selected by Youden's index, this produced a negative predictive value of around 97% in ruling out myocardial injury. And this is in line with what are considered to be state-of-the-art methods using clean 12-lead ECGs and including easier diagnostic targets like STEMI. And in fact, we made this evaluation ourselves using standard 12-lead ECGs on the same patients, and found that, if anything, the noisy, messy, but multiply sampled single-lead waveforms were more discriminating and more performant in identifying our outcome than were the 12-lead ECGs. This, to me, is the most interesting finding here, and tantalizing evidence that for at least some diagnoses that don't have classic ECG stigmata, namely NSTEMI in our case, multiply sampling across time, a noisy, low-resolution, complex signal can actually provide more information than a clean, high-resolution snapshot in time like the conventional 12-lead. This is a unique data set to the ED. We know that our monitor data is messy and noisy and voluminous like the ED itself, but like the ED, it's also complex and multifaceted, and to my mind potentially profound if we know how to look. When we interrogated the attention architecture of our transformer model, we found in fact that the model had learned to attend to the ST segments and T waves of these ECG segments as you'd expect, but very few of the positive cases had classic findings like T-wave inversions or ST depressions. And in fact, when we had a panel of 3 physicians evaluate the same ECG segments and predict myocardial injury, they were only able to perform slightly better than a random guess here, suggesting that this is an inherently difficult task. Even better, as we continue to add patients to the database, we're now finding that after having adopted this transfer learning strategy, we're continuing to see improved performance as we see more patients come through the ED. But is a model like this clinically useful? That depends on your perspective. In a highly resourced academic setting in which you might have available rapid high-sensitivity troponin assays, something like this is not going to dramatically alter our existing workflow. But to me, the potential of this kind of approach lies elsewhere. And when you consider that we're using a very noisy, unsupervised signal not obtained by a trained technician on an ECG, and a signal very similar to that which is increasingly obtained from ubiquitous wearable devices, I believe that there's potential for models like these to expand and democratize the sorts of contexts in which we can do risk stratification for a problem like chest pain. I see this above all as a proof of principle that we can get a lot more out of our data in the ED than we currently do. This is the idea of cross-modal self-supervised learning, which is where we're now trying to go with this line of research. Cross-modal meaning that we are learning across different signals, and self-supervised meaning that rather than manual labeling, we are developing mechanisms to derive outcome targets from the data itself. For instance, in this ongoing work using combined ECG and plethysmography waveforms and their relationship to make near and medium-term predictions in blood pressure, or performing multiple mutual and iterated predictions across multiple waveforms in order to produce an omnibus model of patient cardiopulmonary and acid-base dynamics, which we can then calibrate against blood gases, echocardiograms, and other data. Over enough iterations through this process, we are now trying to produce a model not just for a specific outcome, but instead a representation of a patient's entire physiology as it evolves throughout the ED visit, which can then be applied to a problem of interest. And if this is ever going to be clinically useful, it's going to be through software that interfaces with the clinician, and this is what we're trying to build, a framework to extract and harmonize this data in real time, to train and deploy these models in a unified framework, to be able to leverage this concept of self-supervision on hundreds of thousands of patients, to query a patient's combined clinical and monitoring history, to assess patient-specific responses to interventions, to incorporate learned patient baselines for empiric alarms, and to share data and models across institutions. We are building this framework, and we are working to make our data set de-identified and publicly available to you. But this is my plea for help. We need your help to do this. Most deep learning results, even the most prominent ones, don't hold up in external validation. We need more patients and more diverse patients from more places to build the kind of data set we want. So if your institution stores ED bedside monitor data and you are interested in collaborating, please get in touch with me. Thank you very much, and I'll be happy to take questions. Or if not.
We'll take 2 questions.
Jim Holmes, UC Davis, very nice work. Have you looked at other items besides the EKG for non-STEMI, such as like ventilator waveforms in patients in the emergency department, or other things where you're collecting a whole bunch of data for?
Yes, thank you. So that's what I was getting at impressionistically in the last slides. We did this as a first proof of principle, and we are now working on the mechanisms to appropriately incorporate the different signals. There are a lot of methodologic complexities there, due in part to the different natures of missingness and the sometimes asynchronous collection of different data points. But that's the essence of the self-supervised approach that we're developing. We do have some preliminary results in this data set showing improved performance of sampling techniques that rely in part on sampling triggered by signals in non-ECG waveforms of when an ECG signal is likely to be informative. I think there's a lot of interesting basic science there that to me is fascinating, and maybe I'll be able to tell you about next year if I get invited back.
Okay. I just wonder if you found anything with heart rate variability, because heart rate variability always shows up as an important parameter. You seem to focus on the ST segments.
Yes, thank you. So the question was about the role of heart rate variability, and the answer is yes. We do get into this in not by manual feature extraction of heart rate variability, but through the convolutions that we apply to the ECG sinusoids. We actually end up with a filtered dimension of that data set that reflects several of the common measures of heart rate variability. And they do add to the predictive quality of the model. Something that's interesting to us is that when we then try to compare these empirically learned deep learning results to all of the manually engineered features that we can think of, conventional B2B standard deviation of RR intervals, as well as the standard derivatives of a Fourier transformation of ECG, those measures accounted for only about half of the HRV-like signal that we were getting out of this, which is, again, to me, very tantalizing evidence that there are just more features in the ECG than we even know about.
All right. Well, thank you, everyone, for joining. That's all the time we have today. We're over by 20 minutes. If you have any other questions for the presenters, please come up and ask them directly. Thank you, and let's give another round of applause for our keynote, Plenary Abstracts, and enjoy the conference.